Dr. Kevin Rebe. I'm an infectious diseases specialist living and working in Cape Town, South Africa. I work for the Anova Health Institute. Anova is a non-profit organisation that works to better the health of South Africans in partnership with our National Department of Health. Another role that I play is that I work as part of the EQUIP Consortium. Anova Health Institute is one of the partners in the EQUIP Health Consortium. And EQUIP really is designed to try and bring skills and best practice examples to the Africa region. So Anova plays a number of roles within the EQUIP Consortium, and I serve in a number of different functions within this EQUIP partnership. So one of the things that I do is I run the PrEP technical working group for EQUIP, and this is a group of highly skilled experts trying to develop new materials and new methodologies and new ways of implementing PrEP in the Africa region, essentially looking for ways in which we may have impact on the HIV epidemic and help African countries to reach their 1990 targets. So the PrEP technical working group is made up of a range of different experts that includes physicians, public health people, some statisticians, some health economists, and essentially what we try to do is to develop programs that could be implemented within each of the EQUIP countries. And this includes a range of activities. It may be activities such as advising on PrEP guidelines within countries. It might be doing things like assisting with modelling of costs that countries might incur should they plan to implement PrEP. Or it may be development of protocols that could be implemented and then assessed to see how well PrEP was implemented and how well it may function and what kind of impact it could have in countries. So that's the one role that essentially Anova plays, is by deploying people like myself and other experts onto technical working groups. But the other role is that Anova is an experienced implementer of programs. So Anova has taken the lead in key populations and in pre-exposure prophylaxis or PrEP, and actually is the implementer on the ground that would go and operationalize the plans of the EQUIP Consortium and some of the products that come out of the PrEP technical working group. PrEP stands for pre-exposure prophylaxis against HIV. And it's an extremely exciting and effective new intervention that we're now able to add into the package of care that we have for preventing and treating HIV, that hopefully will really have a big impact on turning the tide of this epidemic. And in fact, I think it's one of the most exciting interventions we've had since triple therapy treatment for people who are already positive. So essentially the concept of PrEP is that you can take a single pill a day composed of two different antiretroviral medications, and taking that pill correctly provides an extremely high level of protection against being infected by HIV, even if one is exposed to a body fluid that contains the virus. In fact, the protection levels are probably in the region of above 90% and even approaching close to 100%, so a very powerful intervention. Now, PrEP is exciting for a number of reasons. Firstly, it is evidence-based and it's been shown to be extremely safe. The side effects that occur in PrEP are extremely minor, they're very easy to deal with, and generally they can be managed quite simply without having to stop or reconsider somebody who's taking a course of PrEP. So PrEP is safe, it's very effective. It utilizes medications that are already in wide supply because they are the same medications that are already stocked by pharmacists for people who are HIV positive needing treatment. So anybody today who is at significant risk of contracting HIV, and that has actually been defined by organizations such as the World Health Organization. These are people or populations where their risk of becoming positive is about 3% per year. So for every 100 people in a population like men who have sex with men, for example, if 3 or more of those 100 are expected to become positive per year, then PrEP would be an effective and cost-effective intervention to try to offer to that population group. So in this intervention, people need to be shown to be HIV negative because it is only for negative people to prevent infection. And if they've had a negative test or a series of negative tests and they're otherwise in good health, their kidneys are working well, then they are potentially eligible for this intervention. PrEP is an add-on intervention, so it's not a replacement for what people are already doing to prevent HIV. So for example, if somebody is using condoms consistently, nobody would recommend to them that they drop the condoms and substitute PrEP instead of. But what we would recommend is perhaps that if their condom use is not consistent, then adding PrEP to whatever condom use they're already achieving may be a very, very good gain in terms of the level of HIV prevention that they can achieve. So although I absolutely believe that PrEP is a fantastic intervention and it's been very useful in my own clinical practice, there remain a couple of challenges, and these are challenges that we're hoping the EQUIP Consortium will start to answer. So one of the big problems that we have is that knowledge and demand for PrEP in the EQUIP countries is very, very low. This is simply because this is a new intervention. Nobody has done it before. There's very little knowledge among individuals in high-risk communities that they actually need PrEP or that they could benefit from PrEP. So that would be one problem. A second problem, and I guess also relating to accessibility, is that funding for PrEP has never really been secure. There's never been large amounts of funding dedicated to PrEP in the world before because the intervention didn't exist. And we now have an issue where many countries are struggling from a budgetary perspective to manage even the HIV-positive disease burden that they have in country. And now there is almost an expectation that they implement this new PrEP development, and they may not have the budget to do that without impacting on the quality of their treatment services. So one of the things that EQUIP will be able to do will be to bring in resources, both technical expertise, on-the-ground staff in some cases, and new technologies and tools that will make it cheaper and more cost-effective for countries to implement the intervention. One of the key arenas that the EQUIP Consortium has chosen to engage with is key population health services. Now, key populations are various population groups who have a particularly high risk of HIV acquisition and transmission. And there are various reasons why this occurs, but firstly, just to name them, the traditional key populations would be people who belong to groups such as men who have sex with men and other gay men, commercial sex workers, people who use and inject drugs. And essentially these populations, because of their behaviors, because of the environments in which they live, which are sometimes very stigmatizing, they have difficulty accessing health interventions, including HIV prevention and or treatment. And we find that rates of transmission are much higher in these key populations compared to their peers in countries. So for example, if we took a 30-year-old gay man and we looked at his lifetime risk of acquiring HIV without an intervention, it would be magnitudes higher than a 30-year-old heterosexual man with female partners only living in the same kind of context. So the thing about key populations is that the context doesn't necessarily really shift their risk of HIV. A gay man is at high risk of HIV acquisition whether he's living in Cape Town, Johannesburg, Maputo or London. He belongs in that key population, and the conglomeration of risks means that his rate of infection could be really high. There are other population groups where we know there's a lot of HIV seroconversion happening. And the prime group is probably adolescent girls and young women. So this group isn't officially a key population, but they certainly are a vulnerable population. They're not a key population because their HIV risk depends on their context. So for example, an educated woman living perhaps in central Johannesburg with a good job and private health care may not be at very high risk at all. She may be married in a monogamous relationship and her HIV risk is zero. But a younger woman living in a rural town or a mining village may be at much higher risk of HIV acquisition because of her socioeconomic and social context. So these groups that don't fit into the key population group are not being ignored. They're still termed vulnerable populations: adolescent girls, young women, migrant workers, prison populations, clients of sex workers, truckers. There are many of them where we can start to identify where HIV risk is significant and where further interventions could be of assistance. it's certainly pretty clear now from evidence that PrEP, when applied properly, correctly, to key populations, could have very large impacts on the HIV rates. So knowing that PrEP is a potentially very powerful and effective HIV prevention intervention, and that EQUIP has both access, funding, determination, knowledge and skill to implement programs in its partner countries, it would seem an obvious fit that EQUIP would want to promote PrEP within its partnering countries. And that really is what we're hoping to do now. So the two best evidence-based interventions to have an impact on a country's HIV response would be to prevent new infections, obviously, and PrEP can do that, and then also to provide immediate testing and treatment for those who may already be positive. And this has multiple benefits. Obviously, those people find out their status early and get correct treatment before they ever have symptoms or side effects of HIV and AIDS. But also we know that if we decrease the amount of virus in HIV positive people who are on treatment, they are far less likely to transmit that virus to their HIV negative sex partners. So both PrEP and immediate test and treat are going to be priority focus areas of EQUIP. Now we believe in EQUIP that PrEP offers a multitude of benefits to any health division that is going to implement it. So not only do you prevent infections in individuals, which is extremely important, you're obviously preventing community infections, because there'll be many members within a community that is offered PrEP that stay negative, don't become seropositive themselves, and therefore don't transmit the virus forward. There's also a whole lot of benefits for the health system. One of the things about PrEP is that it requires engagement and care. It requires people to be linked to a clinic, to be tested and shown to be HIV negative. And then once they're on PrEP, that HIV testing is recurrent. So one of the big benefits of a PrEP project to an HIV response is that your HIV testing rates go up. Your tested proportion of the population can increase. And not only do you test them once, because they're engaged in care, you do recurrent testing of these populations and individuals. That's really important for trying to know the epidemic and to track its course. So recurrent testing is a major benefit. While those individuals are at clinic level for repeat HIV testing and new PrEP medications, a couple of other things can also happen. We can take the opportunity to recurrently screen and treat STIs. So we'll be able to detect more of them and manage more of them in a PrEP program than we might without PrEP. And the other thing that you can do is risk reduction counseling. So since you talk to somebody every couple of months for their revised PrEP script and their HIV test, it's an opportunity to take a sexual history, see where the risks really lie, and to try and work with that individual to make plans to decrease their sexual risk behavior and obviously lessen their chances of HIV acquisition. It's also an opportunity to provide commodities such as information and educational materials, condoms, lubricant, family planning or contraception for women. So I think it actually strengthens a holistic response to the HIV response when you put PrEP into the package of care that you're offering. So although it's early days yet, there have been some real successes regarding PrEP. The evidence for PrEP was available as early as about 2010 to 2012. We were starting to see the initial studies come through. And often is the case with these kinds of new technologies is they remain very theoretical with very little practical implementation, and they don't get to people who actually need them, and that has not been the case with PrEP. So for example, in the developed world, in the US, there are tens of thousands of men who have sex with men who are already taking PrEP. PrEP is offered and paid for by some insurers, and the access points are becoming very defined, and men who want to use PrEP are able to access it. The next step, of course, is getting access for people in Africa. And this is where I think the successes are starting to come. So, for example, South Africa was the first country after the US to release PrEP use guidelines from its HIV Clinician Society. South Africa was also one of the first countries to register PrEP with our Medicines Control Council for the use of tenofovir and emtricitabine, which are the two drugs in PrEP, for the purpose of HIV prevention. And since that time, other African countries have also registered the drug. So it is now registered in Kenya, it's recently been registered in Namibia, and certainly in the Namibia registration we would like to think that EQUIP had a role in terms of providing the material and the pathway to regulatory approval from their Ministry of Health and relevant regulatory bodies. So I think we've seen some successes in countries realizing that this intervention might be suitable for some populations within their countries. We're seeing policies from these ministries of health starting to include information about PrEP and a need to start to at least develop pilot projects for PrEP and hopefully eventually scale them up into full-size and massive projects. We're seeing PrEP being included in antiretroviral use guidelines in various African countries supported by EQUIP. So I think that would be another success. When it comes to on-the-ground provision of PrEP, certainly we've gained experience from a South African PrEP demonstration project for men who have sex with men, and other partners are providing PrEP to adolescent girls and young women, to sex workers, to people who use drugs. So we're starting to deliver the intervention on the ground, but also to learn the best ways of implementing this to get the maximum possible benefit that we can with the best possible efficiencies. So one example of EQUIP's success in furthering PrEP within countries is what has been happening in Namibia. So EQUIP has been working with the Namibian Ministry of Health and a local implementing partner called the Society for Family Health for very many months now, and we're almost there at the point where we'll be starting to deliver PrEP pills to people. In fact, that will happen on the 29th of June. And that really marks a real success for EQUIP. It is the start of something big. I think this has been a learning pathway for everybody. We've developed a lot of skills and materials that can now be utilized by other countries to take them from this path where we have this very theoretical piece of knowledge that needs to be translated into programs that actually suit the countries in which they're going to run. And I think EQUIP has really assisted in developing an effective roadmap that will be able to be leveraged by other countries as they move in their plans to making PrEP available. So I'm extremely proud to be part of the EQUIP Consortium. I think this represents a very important move forward for Africa, for the Africa region, because EQUIP is really the first time that a consortium of Africa-led partnerships or partners and African-led experts have come together to try and provide solutions for countries in our continent. And I think there's really something to be said for local knowledge and local networking, and I believe that EQUIP is going to be very effective in getting novel interventions into countries that have major impact in the quality of their HIV treatment services and of course now in their PrEP and other prevention services.